Hello friends, today we'll be discussing about male infertility, sorry. So before going ahead, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. The link for the notes is given in the description below. You can download it from there, and without further delay, let's get started. So what is infertility? So infertility is the inability of a sexually active couple who is trying to achieve spontaneous pregnancy uh, in a period of 1 year of unprotected intercourse or coitus. So within 1 year, if the couple is unable to achieve spontaneous pregnancy of the unprotected intercourse, then it is infertility. So what are the various causes of male infertility? So it is divided into three, that is pre-testicular or hormonal. Second is the testicular. Fourth is the post-testicular. In the pre-testicular, we have hypothalamic causes, pituitary causes, and exogenous endogenous hormone causes. So these are associated with issues in the stimuli for the spermatogenesis. In the hypothalamic causes, we have gonadotropin deficiency, that is the Kallman syndrome, isolated LH deficiency or FSH deficiency, then idiopathic and congenital syndrome like the Prader-Willi-Bardet-Biedl syndrome. Then we have the pituitary causes where there will be pituitary insufficiency, could be due to any of the causes like tumor, infarct, radiation, inflammation, hemochromatosis. Then we have hyperprolactinemia. Then exogenous or endogenous hormones, that is excess estrogens, androgens due to suppression of the hypothalamic pituitary axis, congenital adrenal hyperplasia, thyroid disorders. So these are all the causes of the pre-testicular cause of male infertility. Then the testicular causes, which could be due to genetic gonadotoxins, systemic disease, defective androgen activity, testicular injury, etc. So we'll see them in detail. So X genetic causes are Y chromosome microdeletions, Klinefelter syndrome, Noonan syndrome, that is 45X or 46XY mosaic form, myotonic dystrophy, vanishing testis syndrome, Sertoli cell only syndrome, and defective DNA mismatch repair. Then we have gonadotoxin, which will have radiation and drugs, systemic therapy involving most of the chronic organs like the renal failure, liver failure, sickle cell disease, and diabetes. Defective androgen activity due to alpha reductase deficiency or androgen receptor deficiency. Injury from orchitis, torsion, or trauma. Cryptorchidism, varicocele, and idiopathic. So these are all issues associated with spermatogenesis. The last is the post-testicular, which is generally due to sperm transport, issues in the sperm transport. So it is divided into reproductive tract obstruction or defect in the sperm function of motility or defect in coitus. So first of all, the obstruction could be due to congenital blockage, example being cystic fibrosis, Young syndrome, that is ciliary dysmotility, idiopathic epididymal obstruction, ADPKD, which will cause epididymal obstruction, congenital ejaculatory duct obstruction. These are some of the congenital causes. Acquired blockages due to vasectomy, vas injury, bacterial infection. There could also be functional blockages. Then disorders of the sperm function, that is immotile cilia as in the Carter-Jenner syndrome, immunological as in antibody for the anti-sperm antibodies, infection, disorders of coitus, that is impotence or erectile dysfunction, hypospadias, timing and frequency of coitus. So these are some of the causes of male infertility. Now I'll be seeing how we approach the evaluation. So initially the history. So very importantly, the components of infertility history. So the fertility history that will include previous pregnancy with all partners, previous infertility treatment, duration of the infertility, female evaluation, partner evaluation, as the chance of pregnancy decreases after 35 years of age. Then the sexual history, timing and frequency of intercourse, ideally it is around ovulation, 1 to 2 day around ovulation. Then erectile dysfunction, use of lubricant because these decrease sperm motility. Developmental history, cryptorchidism causing decreased sperm production, childhood cancer or treatments, mumps or orchitis, pubertal development, that is Kalman syndrome causing delayed puberty, medical history in the form of systemic disease, diabetes, cancer or infection, genetic disease like Klinefelter or cystic fibrosis. Cystic fibrosis may have congenital absence of vas difference. Surgical history, that is orchidopexy causing testicular atrophy, hernia surgery causing defect in the vas difference or injury, testicular atrophy, trauma or torsion, pelvic retroperitoneal surgery or TURP causing ejaculatory dysfunction. Family history for same, medication like testosterone, nitrofurantoin, cimetidine, alpha blockers, spironolactone, opioid analgesic, cytotoxic chemo, and phosphodilator 5 inhibitors like the sildenafil. Social history, smoking, alcohol, steroids, recreational drugs, all these cause affect the hormonal pathways mainly. Then the occupational history, that is radiation, chronic heat, pesticide, aniline dye, heavy metal. These may result in decreased sperm count. Now, after all the history, we'll go for physical examination, that is the secondary sexual characters, obesity. So gynecomastia, decreased body hair, which will be sign of androgen insufficiency, which will be seen in secondary examination, secondary sexual character examination. Then the scrotal examination, that is testis, mild descent or presence of tumor. We'll see for size and consistency, size with help of orchidometer. For testicular volume, consistency normally is firm. If it is soft or hard, it is abnormal. Then we have hypogonadism, that is epididymis can be indurated, tender with cyst, vas for any congenital absence of vas difference, varicocele due to atrophy of testis. Varicocele can be associated with atrophy of testis. Then the penile, that is hypospadias, chordae or phimosis, may resulting in inadequate sperm delivery. Prostate and seminal vesicle, prostatitis, cancer and large seminal vesicle causing ejaculatory duct obstruction. Now we'll be seeing the lab evaluation for these cases. So for lab evaluation, we have semen analysis, which is done generally after 2 to 5 days of abstinence, which will include semen volume, which should be more than 1.5 ml, and it is decreased in retrograde ejaculation, sperm concentration having more than 15 million per ml count, total number of sperm of around 40 million per ejaculate. Both sperm count and sperm concentration and total number of sperm will be decreased in oligospermia. Motility and progressive motility, which is motility more than 40%, progressive motility more than 32%, which will be decreased in asthenozoospermia. Normal forms more than 4% will be decreased in teratozoospermia, and vitality more than 58% will be decreased in necrozoospermia. Then pH will be more than 7.2, leukocyte will be less than 1.1 into 10 power 6 per ml. Seminal fresh fructose is decreased in ejaculatory duct obstruction. Then we'll go for semen culture, which is necessary if considering infection. Sperm function assessment with the help of sperm mucus interaction. Then acrosome reaction testing, sperm penetration assay, anti-sperm antibodies, could be direct, indirect, sperm DNA fragmentation assay, hypoosmotic swelling test. Then we have the hormonal assessment. So if there is primary testicular failure, there will be decreased testosterone and normal LH-FSH. In primary testicular failure, there will be decreased testosterone and raised FSH-LH and normal prolactin. So only the testosterone is decreased, rest all are either normal or elevated. In central cause causing hypogonadotropic hypogonadism, there will be decreased in all testosterone, FSH and LH, whereas there will be normal prolactin. In hyperprolactinemia, there will be increased prolactin and decreased of all other hormones. And in androgen resistance, all will be increased and prolactin will be normal. And the poor secondary sexual characters along with obesity is a measure of increased estrogen. Then genetic testing, that is the chromosomal studies for Klinefelter syndrome, CFTR, cystic fibrosis receptor mutation testing, Y chromosome microdeletion analysis. Then the radiological investigation, that is the scrotal ultrasound, that is for testicular assessment, volume, varicocele, truss, that is for low ejaculation, which will help us in seeing obstruction in the dilated through the dilated seminal vesicles, which will be more than 1.5 centimeter, dilated ejaculatory duct, which will be more than 2.3 mm. Then we have CT MRI for evaluation of non-palpable testes, retroperitoneal pathology like solitary right varicocele, cranial imaging for hyperprolactinemia, that is pituitary adenoma, we'll consider that, vasography, which is rarely done nowadays. Then histopathology testis, that is indicated for the azoospermic men to distinguish between obstructive and non-obstructive azoospermia. We'll go for multi-site FNA of testis and sperms will be retrieved. In case of azoospermia, despite examining the semen pellet, we'll go for vas difference if it is not palpable. Then we'll go for congenital bilateral absence of vas difference. We'll go for CFTR analysis, or we'll go for sperm retrieval with IVF. If the vas is palpable, we'll go for hormonal studies. If there is increased FSH, that is there is non-obstructive azoospermia, we'll go for genetic evaluation and testicular biopsy. If it is present, then we can again go for IVF. Now, if the hormonal study, if the FSH is normal, we'll go for testicular biopsy. If there is absent spermatogenesis, then we'll go for FNA mapping and microdissection. If that is positive, then we'll go for IVF. If that is negative, there are no chances, so we have to go for sperm donor or adoption. If the testicular biopsy shows spermatogenesis positive, then we'll go for obstructive azoospermia, we'll go for genetic evaluation if as per need, and we can go for surgery, that is vasovasostomy and epididymovasostomy. In case of decreased FSH, LH and testosterone, we go for prolactin checkup. If it is normal, then it is hypogonadotropic hypogonadism. Then we have no option other than sperm donor and adoption. If it is increased prolactin, then there is chance that there is a pituitary tumor, so we'll go for MRI and we'll go for pituitary tumor surgery. If there is no visible tumor, then we can go for dopamine agonist. So that will help us in medically decrease the prolactin and raise the other hormones. So this was all about azoospermia. Now we go for treatment of male infertility. So first of all, we'll go for coital counseling therapy, that is timing around ovulation, frequency alternate days, avoiding lubricants and avoiding gonadotoxin. We'll treat the erectile dysfunction with antioxidants, treat with steroids for antibodies, treatment of retrograde ejaculation through imipramine, pseudoephedrine and ephedrine. And also it can be managed with help of ejaculation on full bladder, vibratory penile stimulation. Then correction of hormonal disorders through the hyperprolactinemia, that could be pituitary adenoma and dopamine agonist. Correction of thyroid disorder, congenital adrenal hypoplasia with corticosteroids. Then idiopathic decreased FSH LH with low sperm count can be treated with clomiphene citrate, which is off label, and it blocks the negative feedback by the endogenous estrogen, causing increase in GnRH, FSH and LH. Testicular stimulation with recombinant FSH, HCG and gonadotropin, GnRH. Stop any culprit drugs if they have been. Then surgical treatment, that is varicocele treatment, could be open, laparoscopic or radiologic. Vasectomy reversal, that is vasovasostomy, vasoepidymostomy. Ejaculatory duct obstruction, that is unroofing of the obstructing cyst by TURED, transurethral resection of ejaculatory duct, orchidopexy. Then in special cases, we'll having the IVF, ART, that is intrauterine insemination, IUI. Then you have IVF, in vitro fertilization, then intracytoplasmic sperm injection after sperm retrieval through the vasal aspiration, epididymal aspiration, or testicular sperm extraction. Then sperm or testicular cryopreservation in cases of cancer. So these are all the techniques for male infertility treatment options.